Hello, students. Good evening. I'm Dr. Shimona Garg, your dermatology tutor at Manipal MedAce. So, welcome to today's session of INICET Dermatology Recall. So, in total, you got 7 questions from dermatology. Well, 6 were direct questions from dermatology. One question was an overlap between histopathology, that is pathology, and dermatology. So these 7 questions, I won't term them as tough. Some of them were direct PYQs or direct questions, whereas the other 2 or 3 questions you needed to rule out the other options to reach to the correct answer. So let's discuss them one by one. Good evening. Okay. So the first question, all of the following presents as annular plaque except pityriasis rosea, urticaria, porokeratosis, or tinea corporis. So the key words in the question are annular plaque and except. Please remember that you have to read the question very carefully. They have asked that all of these are annular plaques except. Okay. So annular plaque means the lesion is ring shaped. Good evening, Dr. Vidya. Annular means ring shaped. So there is a central clearing and the lesion presents like this. Okay. So tinea we know presents as an annular plaque with central clearing. Pityriasis rosea. Pityriasis rosea has herald or mother patch in which you can see annular plaque. So this annular plaque has a colorate of scale. Okay. Okay. So these two, you can easily tell that these two have annular plaque. Third, porokeratosis, you don't know since it's a PG level. Okay. Urticaria. Urticaria, you know that urticaria presents as dermal edema or swelling with redness, with itching, and the lesions, they are transient. They are there for less than 24 hours. Okay. So the correct answer is urticaria. So the first one is a lesion of pityriasis rosea, the herald patch. This is tinea corporis. You can see there is central clearing. And this is how porokeratosis presents, annular lesions, right? And this is how a patient of urticaria presents. There is presence of erythematous swellings, and these swellings, they are there for less than 24 hours. So remember that every year you're getting a question on pityriasis rosea. So you should know about pityriasis rosea along with this very nicely. Okay. So pityriasis rosea, there is presence of herald patch. Along with that, there is presence of these kind of secondary lesions, mostly present over the trunk. And these lesions, they are present in Christmas fir tree pattern. These lesions keep on appearing for the next 2 days to up to 2 months. So now you need to know about the shapes and arrangements of various skin diseases. So this question, annular lesions, have also been coming previously. So annular lesions, again, ring-shaped lesions, you can see in granuloma annulare as seen in the picture. In tinea corporis, in borderline leprosy and borderline lepromatous leprosy, and of course in porokeratosis and pityriasis rosea. Okay, so now we have discoid or nummular or coin shaped lesions as you can see in the picture. So this is nummular eczema. Then we have linear nodules seen in sporotrichosis. Then we have target lesions in which there are 3 zones. Central zone of erythema surrounded by edema and then again surrounded by erythema. So target lesions are seen in erythema multiforme, and targetoid lesions are there in Steven Johnson syndrome and in toxic epidermal necrolysis. Next, we have dermatomal distribution. As you can see in the picture, the lesions, they are present along a dermatome, along a nerve. So this is seen in herpes zoster. Again, grouped lesions are also there in herpes zoster. As you can see, there are multiple grouped vesicles. Then we have Blaschkoid lesions, in which the lesions, they are present along the lines of Blaschko. So Blaschko lines are basically the developmental growth pattern of the skin. They represent the skin migration lines during embryogenesis. So the example is incontinentia pigmenti and varicose epidermal nevus, as you can see in this picture. Then the next question, which type of vitiligo progresses initially and then becomes stable? Acrofacial, segmental, focal, or mucosal? Okay, so even if you don't know the answer, we have just discussed that dermatomal or segmental distribution is along a nerve. So it will be restricted following that dermatome, or it will be restricted to that segment only, right? So initially the dermatome will start getting involved and ultimately it will get involved completely. It will not extend beyond that dermatome. So the answer here is segmental vitiligo. Whereas all other kinds of vitiligo can ultimately go into to become generalized vitiligo. So acrofacial, focal and mucosal can go to become can progress to become generalized vitiligo, whereas segmental vitiligo will remain confined to that dermatome only. Okay, so now in the question we have stable vitiligo. So what is the definition of stable vitiligo? Stable vitiligo is when there are no new lesions of vitiligo in the past 2 years. There is no progression of the existing lesions, and then there is absence of carbonization. Okay. So now you can also answer this question from one more angle, that is, if you remember poor prognostic factors in vitiligo. In that, one point was that the poor prognostic factor is non-segmental vitiligo, which means segmental vitiligo is a good prognostic factor. Why? Because it is confined to that particular dermatome only, right? So what are the poor prognostic factors of vitiligo? Non-segmental vitiligo, presence of vitiligo over certain areas like over bony prominences, over mucosal surface, over acrofacial areas, and long-standing disease, then presence of carbonization, and when it is associated with other comorbidities, and if the patient is in old age. Okay, so stable vitiligo is basically a criteria for taking the patient for vitiligo surgery. So now this is a photograph of segmental vitiligo in which the vitiligo does not extend beyond the dermatome. Okay, so the next question is, which anti-leprosy medicine causes pigmentation? Rifampicin, clofazimine, dapsone, or ufloxacin? So the right answer is clofazimine. Okay, so clofazimine is an aminophenazine dye which is orange in color, and it inhibits the aerobic respiration of Mycobacterium leprae. The side effects of clofazimine are deposition of the dye in the skin, resulting in coppery red pigmentation, ichthyosis, and phototoxicity. Also, there is deposition of the dye in the stomach resulting in pain. So every year you are getting a question that what will be the treatment of this kind of leprosy, what pack will be given. So please remember that you have to remember the packs, what treatment is being given, and you need to know the side effects of these drugs also. So now let's discuss rifampicin. So rifampicin, the mechanism of action is that it inhibits the DNA-dependent RNA polymerase of the Mycobacterium leprae. So this is a bactericidal drug. Bactericidal drug. One dose kills around 92% of the bacteria and 3 doses kills 99.9% of the bacteria. Okay, and the side effects include maculopapular rash, hepatotoxicity, and there is orange coloration of sweat, urine, and feces. Then we have dapsone. So dapsone, it inhibits the dihydrofolic acid, and the side effects are, the most important side effect is DRESS or dapsone hypersensitivity syndrome, which occurs in fifth week. The patient complains of erythroderma, maculopapular rash, there is presence of fever, hepatitis, lymphadenopathy, and the patient can also have hemolytic anemia as a side effect of dapsone, and patient can have methemoglobinemia. So this is how a pack of MB multibacillary multi-drug treatment looks. Please remember clofazimine is not there in the paucibacillary treatment. So, a patient who present with the side effects of clofazimine is either taking the multibacillary pack or clofazimine is also given in the treatment of erythema nodosum leprosum, that is type 2 reaction. So, this white one is dapsone. These two, they are 300 milligram each is the rifampicin, and this 100 milligram each tablet is clofazimine. And this is how the patient presents with coppery red pigmentation. So now another important aspect which you should be learning is hypermelanosis due to drug. So you can remember it as mnemonic A, B, C, D in MP. From A we have arsenic, in which you can see raindrop pigmentation. So there is diffuse pigmentation along with macular hypopigmentation. Then amiodarone can cause purple pigmentation. From B we have busulfan and bleomycin. Bleomycin results in flagellate pigmentation. Then from C we have chlorpromazine and chloroquine, which can cause bluish gray pigmentation. Clofazimine coppery red. Contraceptives can cause melasma and cyclophosphamide. From D, we have dapsone. Dapsone gel in acne patients can result in orangish yellow pigmentation. Minocycline given in acne patients can result in blue-black pigmentation. And then Sorolens. So the next question is match the following. In column 1, we have allergic contact dermatitis. So the gold standard test or the investigation of choice for allergic contact dermatitis is patch test. So lupus vulgaris, we can do biopsy, we can do tuberculin test. For tinea capitis, for any kind of fungal infection, the gold standard test is QH. And for leprosy patients, split skin smear. Okay, so again, so for leprosy patients also you can go for biopsy, but when we have these options for leprosy, we will select split skin smear, and for lupus vulgaris, we'll go for biopsy. Okay, so now let's discuss these investigations one by one. First of all, we have QH. QH is the gold standard test for any kind of fungal infection, right? For example, in pityriasis versicolor, what you will see? You will get um banana and meat and spaghetti ball appearance, right? Banana and grapes appearance, right? In candidiasis, on doing QH, you will get pseudohyphae and spores. In bacterial vaginosis, if to the vaginal discharge you add QH, then you will be getting whiff, uh, amine odor, right? Known as whiff test. Then for any other kind of fungal infection for tinea capitis, you have to go for QH, right? Even in scabies, you can opt for QH just to extract the mite, right? Then biopsy is the gold standard for lupus vulgaris, right? Patch test. So these are the patches which we apply over the back on day 0, right? And on day 2, these patches are removed and first reading is taken. And day 4th, we get the best reading, which is the second reading. On day 3rd, on day 7th, we take the third reading, which is for the late reaction of metals, PPT and neomycin. So please remember the best reading is on day 4. The next question: which sexually transmitted infection has developed drug or penicillin resistance? Syphilis, gonorrhea, chlamydia, donovanosis. So the answer is gonorrhea. Okay. So basically, Neisseria gonorrhoeae is one of the multi-drug resistant organism. It has practically developed resistance to almost each and every antibiotic: penicillin, cephalosporins, macrolides, including azithromycin, quinolones, sulfonamides, tetracyclines, to almost each and everything. So, new regimes keep on coming for gonorrhea. For syphilis, in treatment, we give benzathine penicillin. Those who are allergic to benzathine penicillin, then we give doxycycline. Okay, the dose of benzathine penicillin is 2.4 million units, given half in each buttock after sensitivity test. For chlamydia, we give doxycycline 100 milligram twice daily for 3 weeks. And for donovanosis, we give azithromycin 1 gram every week for 3 weeks. Okay. So now you need to know about gonorrhea. Probably there was one question on gonorrhea also. It's not that clear. So please, this is also a kind of previous year question. Please remember gonorrhea, and then we have non-gonococcal discharge. Gonorrhea is caused by Neisseria gonorrhoeae, whereas non-gonococcal discharge is caused by chlamydia, mycoplasma, trichomonas vaginalis, ureaplasma urolithecum. Gonorrhea has the minimum incubation period 2 to 5 days, whereas non-gonococcal discharge has 1 to 2 weeks. Then in gonorrhea, the patient complains of profuse discharge, as you can see in the picture, and this discharge is purulent, milky white, and the patient complains of intense burning. The patient will be having constitutional symptoms along. Whereas non-gonococcal discharge is scanty, mucoid, and the patient has smarty feeling on passing urine. There is absence of constitutional symptoms in non-gonococcal discharge. Then, in gonococcal discharge, what you see is presence of these kinds of gram-negative diplococci. Gram-negative diplococci. Good evening, Dr. Minakshi. So the treatment of gonococcus which we follow right now is injection ceftriaxone. The dosage is 500 milligram intramuscularly stat, given in patients who are less than 150 kg of weight. Whereas for non-gonococcal discharge, we give doxycycline and or azithromycin. So the next question. A mother had painful vesicular lesions over genitalia 1 year back. Baby is born with features of meningitis and fever and rashes in abdomen. Scraping from lesions show multinucleated giant cells. What is the most likely organism? Herpes simplex virus type 2, enterovirus, measles, varicella zoster virus. Okay. So the keywords in the question are painful vesicular lesions over genitalia. And then we have multinucleated giant cells in the scrapings. Okay. Painful genital ulcer disease is seen in chancroid and herpes. Then we have vesicular lesions. So vesicular lesions are seen in herpes, right? So we have multiple vesicles which erode to form shallow erosions, and these erosions combine to have a polycyclic margin. So multinucleated giant cells. So this is how multinucleated giant cells they look like. You can see multiple nuclei, right? Multinucleated giant cells are present in herpes type 1, type 2, and then in varicella zoster virus, which can result in chickenpox, and in herpes zoster. Okay, so now we have herpes, which fits into the question. So the answer is herpes simplex virus type 2. The next question: which histopathological feature is seen in lepromatous leprosy? The options we don't have. Okay, so now let's discuss leprosy. So we have a tuberculoid pole, and then we have a lepromatous pole. In tuberculoid pole, we have epithelioid granulomas. There is presence of epithelioid cells, presence of lymphocytes, and presence of Langerhans cells. Right? So we have epithelioid granulomas. Whereas in lepromatous leprosy, we have macrophage granuloma. Right? So these inside these macrophages we have Mycobacterium leprae. So that's why this is known as a foam cell or a virtue cell. So in the question, which histopathological feature is seen in lepromatous leprosy? We have epidermal atrophy, and then we have a clear papillary dermis, a narrow zone which is clear, up to which macrophage granuloma is not reaching. So that zone is known as Gren zone. So this is tuberculoid, and this is lepromatous. So now let's see. So there is epidermal thinning, and then you can see presence of epithelioid granulomas, presence of epithelioid cells and lymphocytes. Whereas in lepromatous pole, what you can see is again epidermal thinning, and here you can see a zone. This is known as Gren zone, up till which macrophage granuloma is not reaching. Right? So in this picture, here you can see macrophage granuloma and foamy histiocytes. Right? So the question might be they must have asked foam cells, Gren zone, or subepidermal zone, or presence of macrophages, right? So these were all the 7 questions. Probably there was one more question which was again based upon gonococcal discharge only. So I've covered that topic. Pretty much straightforward questions from dermatology. And those which you can't answer, you can always answer by ruling out the other options. That was all from my side. I wish you all the best for the upcoming NEET examination. Hope you all do well. So make sure that you revise the dermatology completely before the examination. And most of them, you can expect easy questions only from dermatology or straightforward questions. You just need to revise them before going into the before sitting into the exam. All the best. Thank you so much.